I'll be talking and giving tips on the basic pearls and perils of biometry. So what is biometry? Biometry is actually the process of measuring various physical parameters of the eye and using this data to determine the ideal intraocular lens power. And what is the most important thing is for gathering, the first thing in this is to gather a good data. How do we do that? And what are the important components of that? The essential components of this are to have an axial length measurement and keratometric measurements. The other additional measurements include the wide to wide and the lens thickness. Whom should be the person who should be doing the biometry? It should be done by a person who's the surgeon himself or a person who's very well trained assistant of yours. When it should be done early so that you get ample time to calculate the IOL power, because you may have IOL powers in patients where you may need to arrange those IOL powers which are out of range. And also you will get ample time to counsel the patient to know what type of refractive error does he want to have. In case you want to have a refractive error, some refractive calculations to be done at the beginning of, before planning your surgery. Keratometry is one part of it, which is basically an estimation of the corneal power. Remember, a good keratometry measurement is very important because it is not only the one which is used in the calculation of the IOL power, but also it indirectly estimates your effective lens power position. And also it helps in planning your astigmatic control during the surgery. Remember, we are actually measuring only the anterior radius curvature, and we are using these readings to predict the posterior corneal curvature as well, using a refractive index of 1.3375. There are various modalities available for this. Most commonly used ones are the automated keratometry or the optical mode. But what are the tips which are important? I'm not going to go into the details of the instruments. What is important is remember that you should always remember to calibrate your instrument, whichever instrument you're using. Ensure that there is a good tear film and untouched cornea at the beginning of measurements. There is accurate centration. For this, you need to occlude the other eye and take average of multiple readings. It should be done in a dark room, and in case there is evident scarring, use the other eye and recheck if there are extreme values less than 40 diopters or greater than 48 diopters, or there is an asymmetry between the two eyes of greater than 1.5 diopters. For excellent measurements, we have ultrasonic measurements and the optical modes. Now, ultrasonic waves, as we all know, basically in this echoes are reflected from the various ocular structures and which are deciphered to use the distances traversed. Now, the tips which are to be taken while doing your excellent measurements using ultrasonic modes is please calibrate your instrument again. Check that you have set it at the correct velocity settings. When you're using the contact method, do only a gentle touch. Look for good ultrasonic spikes. There should be appropriate gain settings on the machine, and also ensure that the patient's eyes are axially aligned. That is, he's fixating on the fixation light of the probe. Take average of multiple readings. Repeat if the difference between the two eyes is more than 0.3. Record preferably before dilating the pupil, and avoid use of any ointments. This is just a photograph. This is just a diagram showing you the reflectivity. All these spikes should be perpendicular to the horizontal at 90 degrees. So, and they should be almost having an 80 to 90 to 100% of reflectivity. What are the advantages of ultrasound? Obviously, it is easy to perform, can work in the densest of cataracts, and it is cost effective. But what are the disadvantages? Obviously, a contact mode causes corneal compression. There is a risk of abrasion, and there may be misalignment issues. A little advantage in ultrasonic measurements is gained by using Prager's shell, which helps us in doing the using the modality, which is the immersion ultrasound. In this, a water bath is created between the eyes and the corneal surface, in which the probe is immersed.
I'm sorry to interrupt you, ma'am, but the screen is stuck and we cannot see the next slide. Others, please confirm.
Is it okay now? Can you see my
yes, we can only see the front slide.
The slides are not moving.
Yeah, it's not.
Slides are not moving.
Can you try once again, Vinita, to take the next slide?
I'll have to stop share and screen share again then. Okay.
Yes, now we can see.
Okay now?
No, go to slide share first and then change the slide and see.
The slide is visible. Just start this presentation.
Yeah, okay. Are they changing now?
No.
You have not gone to the slide share.
I've gone to the slide share.
नहीं
In
तो
my,
hang हो रहा है, ऐसे
my
कर दो,
PC
type
is showing a slide share only.
So select the slides like that only.
It's show like this only without slide share then.
No, slide share is there. I mean, the slide show is not started.
No, I'm on the slideshow only. That's what I'm saying. I'm on the slideshow only. Otherwise, I'll go on the without the slide share then. It's not working. Is
Yeah,
it?
you can select those slides
Yeah.
now.
This is fine. You can just show it like
I'll
this.
just go like this then. Okay. So,
Yes.
so for the optical biometry, as we have already mentioned about the immersion ultrasound using a Pears shell, obviously the advantage of immersion ultrasound is accuracy increases. And other advantages of ultrasonic mode are there, but the disadvantages are similar, and the added disadvantage is the patient can get wet. So the better option is obviously to use an optical biometer, where we are using infrared diode lasers, and we have different machines based on different types of technology. We have the partial coherence based interferometers, we have OLCR based biometers, and we have swept source based biometers. But all of them, what is important in them is that obviously the wavelength of the rays which are used is smaller than the ultrasound waves. Hence, the resolution is far much better. Tips in these cases, again, ensure that while taking measurements, there should be a moist ocular surface, ensure alignment, choose the correct mode, and a slight mid-races may be helpful in these cases, especially when you are dealing with a posterior subcapsular cataract. The advantages more added to it are the very high repeatability, observer independent, fast, precise measurements, and the same machine can do multiple measurements of your multiple parameters. There's no physical contact, no anesthesia is required, there's no corneal compression, and you're measuring along the visual axis. But the disadvantage being obviously it is a little bit more expensive as compared to your ultrasonic machine, and does not work if there is significant posterior polar or a posterior subcapsular cataract. What next? After the data has been gathered, we have to use one or more of the IL calculation formulas. So we have an armamentarium of formulas available with us. Which one to use? There are various formulas based on vergence, on ray tracing, on artificial intelligence. What is more important to remember out here is which formula not to use. Remember, out of these formulas, SRK2 is not now obsolete. This is because I just give an example for that. There are certain excellence at which even a 0.01 millimeter difference causes a change in the IL power of more than 1 diopters. An example of this is excellence of 22 to, you will get a IL power of 22.95 using this formula. And with an excellence of 21.99, you will get an IL power of 23.98. So which formula to use and where? Obviously, this will be taken up by my other speakers. So broadly, for short eyes, you can go for Hofer Q. For average eyes, you can use any of them. For long eyes, SRKT may be preferable. But now with the Hill RBF and other artificial intelligence tools, we can use any formulas. Another scenario after your surgery, after you have done your surgery, would be a scenario where you have done excellent surgery, you have a quiet eye, a pristine cornea, but still your patient is unhappy. And why? Why is that? Because you're still landed with the high refractive error and a refractive surprise. So how can you minimize this? Again, is by need to hit. And then our purpose is to hit the target. So we can start optimizing our results. And there are various strategies for this. This will again be taken up by my next speaker. So I'm not touching on this. And again, remember to be extra cautious, extra diligent in situations where you have special parameters of the patient's eye, because you have to be very, very diligent to have best optical outcomes in such suboptimal conditions. In the end, I would just like to summarize that while doing your biometry, please measure both eyes, always use the correct mode. Remember, most individuals have similar excellence, and most of the corneas are regularly curved. So if you have variations or deviations going from this range of excellence or this K readings, please recheck. Same way, look for asymmetry between the two eyes. And if you do not have a reason or a known documented answer for it, please repeat your measurements. Repeat your measurements if the average corneal power is less than 40 or greater than 48 diopters, axial length is less than 22 or greater than 25 millimeters, or is the difference in axial length between the fellow eyes is greater than 0.3 millimeters, or difference in the corneal power of the mean corneal power is greater than 0.9 diopters, or the difference in the emmetropic implant power is greater than 1 diopters. and repeat on different days with different machines. Use multiple formulas. Change of IOL, remember whenever you're changing the IOL at the time of surgery because of some complication which has occurred during surgery, and you're changing the position of the IOL or the type of IOL, please do the recalculations and also ensure to do calculations according to the position of the IOL placement, whether it is in the bag or whether it is in the sulcus. And also remember to use the A constants mentioned on the boxes of the IOLs, especially when you're using different modalities of measurement. For optical, there are different A constants. For ultrasonic measurements, there are different A constants. And do not intermix them because obviously that will make a difference to your IOL measurement, IOL calculations. Audit your results scientifically and use them to reapply in your practice, re-optimize your results and calculate your A constant.